Hello, everyone. We are live on Facebook now. Just gonna give it one more minute just to make sure there's still people trickling in. So I just wanna give them time to connect to the audio, make sure that they can unmute their audio on Facebook too. Right. All right, so let's go ahead and get started. Before I introduce our speaker, I just want to say, please enter your questions in the chat box, as well as on Facebook in the comments section. I'll be reading the comments on Facebook and on here to ask Dr. Pergam at the end of this presentation. We are going to be hearing about cancer and COVID, the pandemic's impact, from Dr. Stephen Pergam from the Fred Hutchison Cancer Center, Cancer Research Center in Washington State. Dr. Pergam is an infectious diseases physician and researcher, and he specializes in the prevention and treatment of infectious diseases, particularly among patients whose immune systems are compromised due to cancer, chemotherapy, or transplantation. He develops methods to protect against potentially dangerous complications such as fungal infections and hospital-acquired infections caused by microbes that are resistant to antibiotics. So he is going to be talking about COVID-19 and cancer. Welcome, Dr. Pergam.
Thank you so much for having me. And if my volume isn't good enough, let me know and I'll talk a little louder. But really appreciate the invitation to talk to the Susan G. Komen group in Chicago. I'm a Midwesterner at heart. I grew up in Omaha, Nebraska, so big fan of Chicago. So I'm happy to be here. So I think just make sure I can get my slides moved here. One thing that here we go. Just some disclosures quickly. I have received some grant support from a couple of different companies not related to COVID at all. And I have been working on a clinical trial that enrolls patients where the vaccines are given by Sanofi Adventis, but it's an NIH-supported trial, so I'm not receiving any support for that. Just to be clear, none of this is related to COVID at all. So just an outline of my talk, I'm going to be describing a little bit about the information that has been published to date on COVID and cancer, and the theme there is avoid COVID-19 if you can. I'm going to discuss some of the challenges in diagnosis, management, and other outstanding issues. And one of the issues that comes up for us all the time is this COVID or is it something else? And then targets of prevention. And I really want to comment to all of you that really what we're really focusing on as much as possible is prevention is worth the investment. We really want to do all we can to do work to prevent COVID because treatment choices are somewhat limited at this point. And then I think, what do we do to protect yourself, or what can you do to protect yourself? And I'll go through something called the 6 C's, which I use to really advise our cancer patients. It's a little bit of a riff on something that the Japanese have put together at the beginning of the pandemic, and I really liked it, and I built on it with some other aspects. And I'll go through that at the end, just for anybody as take-homes. So, early on in the pandemic, this was, I think I had more hair at the beginning maybe, and maybe it all came out as this got more frustrating. A lot of this was related to me thinking about having to wear Tyvek suits and thinking about the pandemic. It basically was a lot of sleepless nights as I knew this was coming. I'd been following the news pretty closely, and basically in January, I'd seen some Twitter comments about transmission of unknown flu in Wuhan, China, and I'd really gotten concerned about this. I've been watching very closely. The reasons I was concerned is cancer patients often are older. Now, that's not true for breast cancer patients necessarily, but in general, cancer patients tend to be older patients. They often have multiple comorbidities, meaning they might have underlying heart disease or lung disease or other things as well, which are known to be risk factors for COVID-19. Most of our cancer patients are immune suppressed in some way. They're receiving chemo, radiation, or something else that puts them at risk. And then our outcomes for patients from other infectious diseases that are known to be respiratory viruses, like influenza and respiratory syncytial virus, which is a disease that causes croup, are known to lead to more lower tract disease events and some death in cancer patients. And so we were concerned this could be worse in our populations. Despite many centers doing a lot of work to prevent transmission, we knew that respiratory viral pathogens can still transmit within our cancer patients, and so we're concerned that we wouldn't have total control of the situation. And unfortunately, as many of you know, cancer surgery, cancer radiation, cancer treatment really can't be delayed. And so there wasn't a way to sort of slow down the process necessarily for how we treat patients. So from the beginning, we said our cancer center is not going to close. We just have to rethink how we're going to do this. And so it caused a lot of us to sort of challenge how we treat patients. So I think the early data, when we talk about outcomes, was very concerning. And the best way I can describe that is there was a study of the first 18 patients from China. So there were over 1,500 patients that were diagnosed with COVID at that time. And the 18 that had cancer as associated finding showed an increased risk of clinically severe events, and they use what they call a composite endpoint of admission to the ICU, needing to have ventilation or death, versus those who didn't have cancer was about close to 40% that needed really ICU level care. There was also a higher risk for those with chemotherapy or surgery in the prior 30 days versus those who had no treatment, which was something we were obviously have a lot of patients in our center that are in that situation. Apologize, something's flying over my house. Give me a moment here. I also saw this as a bad combination. It's advanced aged, it's weakened immunity, and it's these comorbid conditions like heart disease and lung disease that all sort of can combine into this bad mix in the middle and a risk for complications. And so we started to look at data as they started to roll in from different studies. What you're seeing is I've highlighted some of the complex issues. And what I think for many of the breast cancer patients to be noting here is a lot of what we call solid tumors like breast cancer. HM in this situation means hematologic malignancies, things like leukemia. You can see that it was older age, being male, having comorbidities like high blood pressure and diabetes, and then having solid tumors were increased risk. When you look at overall mortality, you can see that it's substantially less at 30 days than what was initially reported. So down around 20 to 30%, down to even 10 to 12%. If you go further down, these are all different studies from around the country and around the world. You're again seeing these comorbidities, older patients, and solid tumors. There is this question in some data from colleagues at Memorial Sloan Kettering and data from Wuhan, China, that potentially immune checkpoint inhibitor therapy, which is used for some particular types of cancer, you can have an increase in response and maybe more severe disease. So basically the theme was that mortality ranged between 10 to 30%, which for many of us is substantial and still really scary. But a lot of those were really the older patients. They had comorbid conditions. Many of them were late stage cancer. They had high grade tumors. And the really high-risk patients were hematologic malignancies, people with leukemia and transplantation. The challenges in determining the cause of death in COVID-19 versus the death of some of these other patients that were related to their cancer could sometimes be a little bit difficult, but certainly COVID-19 played a strong role in many of these. And what we saw was that, again, the solid tumor, similar to breast cancer patients, or solid breast cancer patients are a subgroup of that, were significantly higher than those who had leukemia and other hematologic malignancies. And so what that told us is this was an exposure issue. So patients with leukemia are often inpatient in more protected environments for longer periods, where solid tumor patients tend to be in the community interacting. So they may come in for a day for their chemo, but are often going back out into community areas where their potential for exposure is still quite high. I mentioned immune checkpoint inhibitors. That's not really an issue with breast cancer at the moment, but then people who are undergoing active or ongoing chemo, unlike the early data that came from China, did not look like it was particularly associated with death, but was linked more so to the need for hospitalization. So I think what the important thing to remember is that when we look at COVID-related complications, everybody focuses on ICU admissions and death, but those are not the only issues. We're starting to see patients who have prolonged symptoms, particularly fatigue, sometimes even fevers. They have cardiac complications. There's been reports in the Midwest, particularly one of the reasons the Big Ten football group was a little bit slow to allow their players to start again was because of this particular concern of cardiac-related complications. Patients who develop more severe admission and need to go to the ICU might develop more chronic lung injury. Some patients have complained of neurologic issues where they have trouble with memory and other issues. And then clotting complications have been something that's been problematic, where people get a deep venous thrombosis or a blood clot in their leg. They may get a stroke. It's also been associated with heart attacks. And there's a thought that these clotting complications can play a role in the lung injury. And so many centers, when patients with COVID are admitted, are often, in some situations, started on blood thinners because of this particular known risk. And there is this new sort of description of what are called long haulers. I don't know if people are aware of this term, but these are patients that develop COVID-19 and then go on to develop prolonged symptoms that last for months. In an Italian study, 87% of hospitalized COVID-19 patients had at least one symptom that continued for 2 months after the onset of the disease. And even in studies of mild cases where people are not admitted, there's about 35% of those who were not back to their usual state of health for 2 to 3 weeks. And that's really different than flu as an example, where people will be out for about a week, but then usually back on their feet relatively quickly. The most common chronic symptoms that people describe are fatigue and just an overall feeling of what we would call dyspnea, or that feeling of shortness of breath, where they just can't get their breath. And particularly that feeling of what we call dyspnea on exertion, or that feeling when you're walking or moving places that you just can't catch your breath. So walking upstairs or walking around the block, where they feel like they're unable to get that good oxygen exchange in their lungs like normal. And there's a number of people who've had to stay on oxygen for longer periods of time, including those in the ICU who've had chronic lung damage. So I think there's a whole host of other things that we're beginning to learn about what COVID does and what its long-term consequences can be. I think we're also challenged by making the diagnosis, particularly when it comes to cancer patients, because fever, cough, chest pain, shortness of breath, and other COVID-19 symptoms are really common in our cancer patients. So who do we test? So a breast cancer patient who has involvement of their chest or has metastatic disease in their lung might have a chronic cough or might have chronic chest pain. They might have chronic fatigue. How do you know when COVID fits in that? Additionally, the sensitivity of some of our PCR assays may miss cases. They're not perfect. Ours is pretty good locally, but not all are as accurate. And so there's been concerns that despite testing, we might miss patients. In many communities, testing results remain a major burden. So trying to get a test quickly that turns around that you can use to help make a decision about next steps can take more than a couple of days, and sometimes up to a week. And so that can be very challenging for patients to figure out when they can get their next cycle of chemotherapy, as an example. There is certainly questions about how do we use serology or antibody testing in cancer patients, but right now that's really a data-free zone. We don't have any data about what that looks like. And there's a number of larger trials that are beginning to capture information on this, but we just don't know enough. We think that serology is not going to be as accurate in patients who are immune suppressed or have weaker immune systems. So at this point, we're not sure. And then how do we address these patients with chronic symptoms, fatigue, maybe they have lung mets and cough? It can be really hard. So if somebody has a chronic cough, how do we separate out what's COVID and not? And so we've developed some policies where we really ask patients about changes in their symptoms. We've also set up some systems where we've tested people more frequently on a sort of more routine basis to better evaluate those who have really severe chronic conditions. It can be very difficult to know when that happens in certain individuals. And remember that not everyone with COVID-19 feels sick. In a report of 238 young adults, U.S. service members on that naval aircraft carrier, 1 in 5 had no symptoms. And many will present and be able to transmit an infection without having symptoms initially, and will go on to develop symptoms later. So asymptomatic transmission, well, if you'd asked me early in the process, I was not as convinced about. There's clearly strong evidence that this occurs. And so patients will often be positive and potentially able to transmit the disease before they can develop symptoms. Now, most go on to develop some sort of symptom, but not all do. So when we think about additional challenges for cancer patients, we know that they can shed these viruses for long periods of time. Normally, when someone gets infected in a normal host, let's say it's a 25-year-old, they may be positive by what we culture, where we can actually culture the virus for about 10 days. But that molecular test that identifies it can be positive for longer. And what we know is that in patients who are older, who have weakened immune systems, who are being treated for cancer, they may be positive and be culture positive for longer. So maybe have the ability to spread to other patients for longer periods of time. And so current CDC guidance is for immune suppressed patients or those getting cancer chemotherapy to be in isolation and protected from others for at least 20 days post the start of their symptoms and without fever, and have their symptoms improve before we remove them from isolation and where they can go back out in the community. That's a long period of time. And then we don't really know, but we try not to retest those patients if possible. We aim for about 3 months, but that's not always feasible within our systems. And just to be clear, this is an example. This is an early paper. It has not been peer-reviewed, but it's by my colleagues at University of Michigan, the Loring Lab. And basically, I think this is really an important example where a patient who had lymphoma, who was treated, a man in his 60s, was able to shed culturable virus for 120 days. So this suggests that potentially patients in these situations, particularly those with hematologic malignancies, can shed for longer periods of time and potentially be infectious to family members and others in the community. So I'll give you an example of why this is challenging. So we had a 46-year-old Latinx female with breast cancer who had been planned for surgery for a lung nodule, concerned that this might be malignant, a new evidence of metastatic disease. Pre-procedure positive COVID-19 test had been done, and so waited 2 weeks again for pre-planned surgery, was a positive again at 16 days post-illness, and then further delay, finally cleared her virus from testing at day 23. And so that was a 3-week delay before she could get surgery for this lung nodule. Now, luckily, the surgery indicated benign disease, and this was not metastatic disease. But you can see how a 3-week delay could be incredibly difficult for somebody to know exactly what that means. And I'm just making sure, please let me know if you can't hear me. If I lose you at any point in time, Komen Chicago, just give me the heads up. So the challenges for repeat testing. There is occasionally patients who go through this process. I mentioned this whole thing. A 46-year-old with new onset breast cancer developed fever with chemotherapy, required an inpatient admission, had to have a CT scan, and eventually needed a bronchoscopy, where this is a lung wash where they go down into the lung and sample the deeper fluid in the lung. Needed 6 nasopharyngeal swabs, and I'm showing you an example of what this looks like. These are very uncomfortable. If you've ever had one, I'm sure many of you have. I have. They're not great feeling, but had 6 in 2 weeks because of the potential risk to transmit this to staff. So repeat testing is becoming an issue now where patients are getting very frustrated with the number of samples that they need. So let's get into treatment a little bit. What do we know? And I'm going to do very limited discussion here because there's just, unfortunately, not too much I can talk about. So treatment options right now, and I did forget one to put on here, and I'll discuss it as well, but right now there are few options to date which have shown benefits. Remdesivir, which is an IV formulation, it's an antiviral agent. It's only an IV formulation, and it is primarily reserved for hospitalized patients with early severe disease, shown to decrease the length of stay in hospitalized patients, which is an important endpoint. And so is isolated and only used for inpatients, particularly patients who are on oxygen in most locations. Dexamethasone, which is a steroid, is also shown to decrease mortality, particularly for those on oxygen and in the ICU, and is a relatively more available drug, and so has been used quite frequently. The idea behind this is it slows down a robust immune response, which can lead to severe complications. Chloroquine, which has been discussed sort of ad nauseum in the media, unfortunately during multiple inpatient and outpatient studies to date have shown no benefit. And so we don't recommend this. It's not recommended by the NIH treatment committee and currently is not in our most of our guidelines for treatment. Another drug called tocilizumab, which is a monoclonal antibody against the immune system's response, usually particularly IL-6. Generally, data has not been super supportive, but there's mixed data. So some suggest potentially benefits and others do not, maybe dependent somewhat on when the therapy is given. It is expensive. And so again, only an inpatient therapy. There are future monoclonal antibodies, which look really interesting, both for treatment and for prevention, but those are in clinical trials. And then the other piece that I didn't add in was convalescent plasma, where somebody who's been known to be positive they go and donate their plasma, and then that's given to someone who's positive. There's some indications in a large non-randomized study that it might be beneficial for patients that was run out of the Mayo Clinic, but currently many investigators are not convinced that it should be used for all patients. So there continue to be some discussions about how it should be used appropriately. Unfortunately, we're not going to have randomized clinical trials to know the answer to that because it was approved early, and so it's currently being used. So I think a lot of people are using it, particularly in high-risk patients, but I think there's still some questions about who should get it. And anytime you're giving plasma, there is potential risks associated with plasma donations. I will point one other issue out is that antibodies don't last that long. So when people donate, they may not have sufficient antibodies to give to those who've previously, to those who are recent positives. So the real benefit in convalescent plasma is those who have really high titers of antibody. And that's actually a smaller percentage overall than those who do donate their serum. Treatment limits, again, there's no outpatient available treatments at the moment. People are working on this, but at the moment, there is no agent that is currently available. Most treatments target later disease when patients need oxygen or in the ICU. They're using some of these drugs earlier, but it is concerning for most patients that there isn't a lot available. And then remdesivir does have some availability limitations at the moment, although it seems to be in good numbers at the moment in certain areas, but some hospitals have had trouble getting sufficient supply. And then there's really not much available at the moment that we can help for somebody who's been exposed. So as a post-exposure prophylaxis, where we give you the drug to help prevent you from going on to develop that complication. This was studied for hydroxychloroquine, and unfortunately it didn't work. That was done by David Boulware and his colleagues in Minnesota, a really nice study, and then was followed up by another group that unfortunately showed it did not make a difference in those particular patients. So important data, but right now there are no agents available in that situation. So I think really, I sort of really feel like the way forward for us, at least for many of the patients who are going to be listening to this, I hope, is really about prevention. And I say buckle up the next million miles, because it is truly going to be a longer haul. I think it isn't something that we know exactly when we'll get to the point where we'll have more community immunity, or what some people call herd immunity. There is clearly still more COVID in the system, and I think we're worried about a really an increase in the fall. So important to keep in mind that prevention is really where we need to be. We need to be focusing right now. So prevention is key. So some of the things we did within our system, within the cancer center, was to screen everyone. So everyone who enters our clinic or inpatient units, they all get screened with questions about their symptoms, and then all inpatients, they get tested. Employees who are screened, employees are screened upon entry into the clinic, and then tested and sent home, or if they have symptoms. And then any symptomatic patients, we try to defer for a later visit if possible, or if they need to come in for treatment, we test them and then wear appropriate personal protective equipment. Really hard is how to deal with visitors and family, because we often don't have sufficient supplies to do testing for everyone, but that's been an ongoing process that we're continuing to work on. We have done on-site testing for symptomatic patients, as you know, our first floor in the cancer center is a sort of a triage center. So anyone who walks in, they're checked for wearing a mask appropriately, and then they're tested if they're symptomatic. We had drive-through stations outside the clinic areas, because we were calling patients prior to their appointments to make sure that anyone with symptoms was tested prior to their appointment. So that was a lot of work in the early phases. We had these in sort of old garages and the research areas. Those are no longer being used because our numbers have dropped quite substantially in Washington State, but it really helped us to increase local capacity for testing. And we tested all symptomatic employees and those exposed during work, including some family members as well. And then we've had some policies for testing caregivers and family that have continued to be utilized, particularly using other testing availability that's in the community. And whenever we have a situation where we're concerned and we want to do something addition, we'll add this to a testing for a family member if needed. We developed sort of, you know, a way to forward is all the different steps. So it's hand hygiene, we've increased cleaning, we wear masks, we do symptom screening, we do physical distancing, we do testing, staff education, communication, and of course, telehealth and remote work. These were all ways we could protect our staff and our patients. So universal masking, and really what that has been is, this was something that I think many of us were not super on board with initially, but we've come to realize the real value in this. So universal masking has two different aspects. One is when you enter into a clinical space, everyone is masked. That means staff, patients, caregivers, anyone who enters in our facility, even somebody who's delivering supplies for the lab, like blood tubes, because they work for a delivery company. They must wear a mask when they enter into our facility and get screened for symptoms. Anyone with symptoms is not allowed to enter the space unless they're a patient and are being tested. And that's really important, because masking is a critical piece, and masks are not only universal but extended use. So anyone who enters our facility is wearing these masks for the entire time they're there. They're allowed to remove their mask to eat and to drink, but otherwise they should be wearing that the entire time. In the outpatient clinic, it's pretty easy to have the patient masked and the provider masked more frequently at the same time. In the inpatient service, it's hard to make a patient wear a mask the entire time they're inpatient, but we do try to do that in some aspects if possible, because it can help both sides for potential transmission. And then we've added in eye protection as well. So that's the second piece that's been built into this. And we've increased our testing quite a bit. So pre-visit symptom screening and testing for all asymptomatic patients. We do pre-surgical or pre-procedural testing when we have situations where anesthesia would need to be involved. We do pre-admission testing for every single patient who's admitted. They're tested for COVID before their admission. And then in some of our high-risk patients, we actually do weekly surveillance testing. We don't use the NP swabs. We use a softer swab that goes into the anterior portion of the nose, but we still do consider this. And this is just an example of all of the testing that happens within our system. There are not very many, and it's really hard to see. There's yellows that are positives here. We do a lot more testing than there's actually positives within our system. So we set up the system to do more testing and to make sure we weren't missing cases, we could isolate those as needed. And when you look at our patients, we've tested 3,200 patients, over 8,000 tests, and only about 3% of those, despite higher levels in our community, have been positive. So we've been able to keep them protected. And I will tell you that the vast majority of those patients acquired COVID in the community. Very few, I honestly cannot give you a number, probably 1 or 2 that we maybe had a suggestion could have been exposed in the clinic space, but we cannot document that that's where that was acquired. Nearly every single case has been acquired in a community space. And then with staff, it's the same. We've tested over 1,500 unique staff and at very low rates. Remember that staff have worn personal protective equipment for a little bit longer, and so we knew that those rates would be lower. Again, all staff who've been positive have really been related to community exposures. We've really limited any intra-staff transmission events by appropriate masking and social distancing, which has really helped us to control any potential exposures to patients as well as our healthcare workers. So really low numbers overall, and again, lower than the city. I think there's 2 reasons. Part of it is our patients are already more nervous, so they're going to be more protective, but it's also the things we put in place to protect them. It also means they have families that are more focused on preventing exposures. And then with staff, it's the same. We really encourage them to be cautious when they're out in the community and they're not working specifically with us, and we're testing them quite frequently. So I think vaccines are really exciting, but right now most are in phase 3 trials for normal hosts, but not cancer patients. There are multiple vaccines using new technology, mRNA vaccines. There's an adenovirus vector vaccine as examples. They're not currently in production for other vaccines that are being used in these trials. We do not expect that vaccines will be available until 2021. The first available vaccines will likely go to healthcare workers as a primary target, and those who are at high risk, particularly the older population. But we expect that most of these vaccines will have responses that will not last for years, and there is a possibility we may require yearly revaccination. That's data that's unknown so far. And then response rates in patients who have weakened immune systems, we really don't know. That will be data that will happen later on. So we're not really sure how this is going to roll out with cancer patients yet. Something that is clearly something that all of us working in the cancer space are thinking about quite a bit. So let's talk about some challenges. I mean, obviously, you guys have heard about personal protective equipment, the lack of masks. We've had so many strange supply chain problems. Something like the thermometers that have a little plastic cap that you put under your tongue when you visit your clinics, those have been hard to get. We had issues with getting appropriate gowns. We ran out of hand sanitizer or difficulty getting hand sanitizer. Clorox wipes, things that no one would have expected would have been low initially became problems. Even swabs to test patients, we were struggling to have enough available. We've changed our guidelines so many times as we've learned about the disease that has caused a lot of challenges for both patients and for our staff. We still struggle with caregivers and families, and this is really hard, particularly when people want to come into the hospital to see their loved one, and there's limitations. Right now, we're limited to 1 visitor at any point in time, and during the high points, we had more in our community, there were no visitors allowed in the hospital, and that is very hard for patients who have severe disease or complications. You know, social media and print media have been very hard to follow because there's lots of different data that's being presented. Things are coming so fast that it sometimes can be hard to tell
what is real and what's not. And so there's a lot of disinformation that unfortunately has been in social media that has really hurt our ability to get things under control. And as you can see, I'm sure, the differences in how states approach COVID-19 has made this very challenging and has really been difficult for cancer patients in places where masking is not routine. If you walk around Seattle as an example, the public health department in the state of Washington have been very, very supportive of masking, and nearly everyone is masked when you go out in public, unless they're out walking their dog out in the fresh air with lots of space around them. If you go into any public space, everyone is masked. That's not true across the country, and I think we've seen this as schools and colleges have been opening. We've seen more outbreaks, and we do have concerns for what's going to happen in the fall. Sorry, I have a question here. Oh, okay. And then community exposures continue to be big ones where people's families, people's contacts and others they hang out with may not follow the same guidance that the cancer patients are. And some of them, frankly, it's not about the fact that they're not trying to do everything correct, but they have to go to work. And these are essential workers who work at the post office or drive Uber or work in food service industries where they have to go interact. It can be very difficult to protect yourself all the time. And so one of the challenges that we run into is that there can be exposures within the home or within social environments. So that can be a challenge and something that we can't always control despite our best efforts and despite patients' and families' best efforts to do this. It's just one of the realities of COVID-19. And I think, unfortunately, this affects our underrepresented minority communities much more specifically because they're often multi-generational families that living in homes. There is less opportunity to get away. They may have less access to a computer, and socioeconomically, they have to work. So this can be really challenging for a lot of our communities and something that has been very concerning for all of us. So where are we in Seattle? Well, currently we had our first wave in the early portions of March getting into April. We did great in controlling. We went back up in August and we are coming back down. So we had our sort of bi-wave of the first wave, and we're kind of waiting for the next wave to begin to come through. Currently, we're at about 2% positive tests within our community. I think at the last note, we had a few inpatients that were positive, but very few. Chicago, very similar, around 4%, and it seems to be going down. I took this off yesterday from the Chicago citywide positivity rate, and you can see that it's been relatively flat for a while here. So testing has continued to rise, but the number of positive cases has been pretty stable. The concern we have is we've seen increasing rates in Europe. In England, France, and Spain primarily. You can see this early wave in the early days around Italy and Spain, and now we're beginning to see the second wave beginning to increase. We're seeing Italy increasing again, and this is concerning because they're a little further in their fall season, and it may be indications of where we're going next. As you can see, you look in the United States, and this is from an NPR piece, the orange is sort of moderate rates, the blue is low rates, the yellow is sort of low to moderate, and red is really high rates. You're seeing a lot of the rates that are increasing tend to be currently in the Midwest. And so we're starting to see some increasing numbers in the Midwest as our next location. But I think we're all watching really closely because as the fall season comes and we move indoors when it's cold, there's going to be more social interactions indoors that might potentially increase risk. So I also want to bring up really quickly influenza because it's important for 2021. Early data from Australia, when you looked at centers that were testing influenza in their Sentinel laboratories, over 400,000 samples were tested and only less than basically 0.5% were positive. Normally, June, July, and August is similar to our winter months. And as you can see from this, there's basically no positives during that period of time. So they have very little flu this year, We hope this is an indication it will be a low flu season, but we don't know what that looks like yet in the United States. This is data from what's called the SCAN study. It's a study that's done with public health here in Seattle, where they're testing random individuals in the community. And what we're seeing here, if you look a little bit past June, that brown at the bottom is COVID-19, and that yellow is the common cold or rhinovirus. And so we're starting to see a little bit of increase in rhinovirus in our community. And so what that's indicating to us is maybe some increasing transmission, particularly in some of the preschools and other locations where kids are getting together. But this is something that we're watching really closely. We haven't seen an uptick necessarily in COVID, but if we start to see rhinovirus increase, that could potentially indicate that may happen. Oftentimes, flu and rhinovirus are not always linked. Sometimes rhinovirus levels are low when flu rates are high and when coronavirus levels are higher. So we just don't know yet what that's going to look like. So it's a lot of questions, but I think what you can see is there's a lot less respiratory viruses in this particular time frame. Good news, but also something we need to continue to fight against. And then if you look at data from how we did this, you can see where the stay home, stay healthy was around April 2020. We had mask recommended in June, and then we got into businesses opening somewhat in August, around August, and you can see starting this increasing rates a little bit. So small bits and pieces that can tell you how social distancing can be really important and how these phases might have helped us specifically in Seattle. What we don't know is how do influenza and COVID-19 interact. It's possible that they're competitive and that they both targeting the same areas, and maybe this is not, they won't interact. I'm not convinced of that because they both use a specific different receptor in the lung and in the airways that I think would not suggest that they're competitive, but we don't know that. It could be that they're synergistic or that leads to more complications. We don't know, does masking and social distancing help to limit influenza? I think likely yes. Influenza is actually not as contagious as SARS-CoV is. Generally, you can be asymptomatically infected about a day beforehand. SARS-CoV can be longer than that. And in general, if you look at how many an individual with influenza will pass on to those at risk, it's about 1.5 people. When you look at SARS-CoV, it's anywhere from 2.5 to 3.5 if you do nothing. And that is exponentially a larger number that you will see large outbreaks grow very quickly. We don't know how many Americans will get vaccinated compared to usually. I saw a report recently that 1 in 3 parents may not vaccinate their kids for flu, and that's not a good sign because we really want that to be something that's important this year. If we see lower numbers in other countries, will this mean fewer introductions into the United States? That's possible. And we'll start to see some early seasonal reports. There's very little circulating influenza at the moment in the United States, so we're going to be watching that closely. Remember, for vaccines, standard vaccine, quadrivalent vaccine for those 65 and under, high-dose vaccine for those 65 and older. Some people ask about the high-dose versus adjuvanted vaccines. I think they're both effective. I think the high-dose vaccine may be somewhat better for cancer patients, but it's really unknown. So whatever you can get in your local pharmacy, just make sure you get vaccinated. There's a little bit about egg-based versus cell-based vaccines. I wouldn't worry too much about that. I would just get vaccinated. And then for the live virus vaccine, the little spray that goes in your nose, that's really better for kids and not for people who are actively being treated for cancer. So get your flu shot before the flu gets you. Get out there and get it. It's an important step. You do not want to develop respiratory symptoms with flu, have to go to the hospital, and potentially be thought to have COVID or potentially be exposed to other people in ERs. There might be COVID there. So be sure to keep yourself safe and get your family and yourself flu vaccine. So let me talk about the 6 C's, and I'll go through this will be the end of the talk now. So I stole this from the Japanese. So the first 3 are avoid crowds, avoid close contact with others as best as possible, and avoid closed spaces, and particularly closed spaces when you're interacting with other people, sort of in a home where there's not good air exchanges. This does not mean avoid your appointments or treatment. Continue to communicate with your team is key. If you're concerned, talk to your oncologist, your advanced practitioner, or your nurse. Organize a telehealth visit to check in if you don't need to be in clinic. Wear a mask to clinic and follow the clinic ground rules wherever you're being seen. Make sure you call ahead if you have any even mild COVID-19 symptoms. And remember that you can expect some of those symptoms to be related to your therapy, but if you're not sure, make sure to talk to your teams about that. Clean your hands frequently, wash or gel them whenever in public spaces. I have hand gel with me in my pocket at all times, at all desks, everywhere I am. I have it in my car, and I use it quite frequently. Cover up with a mask. Going out in the clinic, wear a mask on a regular basis. Use a mask that covers your nose and mouth. Homemade masks are best when they're using multiple layers of fabric. If you don't feel like sewing or can't, like me, there are lots available for purchase, and many cancer centers are making them available for patients. And avoid masks with a valve on them because they actually exhale what you're breathing out. And one of the advantages of masking is it's particularly beneficial for protecting people around you. So the more people that are masked around you, the better it is for you. So avoid those valves if you can. Wear a mask when going out into public places. Take off after use and wash daily. Have a few backups that you can rotate. Talk to friends and family about masking when they're out and about, and make sure that anybody who comes into contact with you is wearing a mask, if at all possible. If you go to a place where there is no masking required, as a cancer patient, I would strongly consider that you take your business elsewhere. And that can be really hard for patients, but I think it's super important, particularly when they're places that you're used to going. But it is your life, and you do not want to get COVID if you can avoid it. So what I think about this is exposure levels. So, when you go to a hospital, we're all wearing masks and everybody's protected. This is what it looks like in the sporadic exposures in a hospital. When you look at an inpatient, at your home, lots of exposures can happen because you're interacting with people all the time. You're sitting on the couch together, you're sleeping in the same bed. And so making sure your family and others are protected as best they can and be thinking of you when they're going out into public spaces is important. So have these conversations about masking and have them be as cautious as you are when they're thinking about this as best as possible. And so one way to think about this is, imagine you're on a 12-hour transcontinental flight. Which is worse? To have a stewardess who walks by and gives you a drink every once in a while, who exposes you to something, or to be sitting next to somebody like this, who is sick, not feeling well, coughing and sneezing and carrying on. This is a situation where your risk is going to be higher because it's a more intense exposure and a longer period of time you're exposed. So if you were on a plane in this situation, I would ask to be moved by a stewardess if possible. And that's not always easy to be done. I'm not sure many of you are flying anyways, but it's something to keep in mind. Yes, a stewardess might potentially infect more people overall in a plane, but for an individual, that risk is going to be less than it is sitting next to somebody who's really symptomatic and positive. And, these are the situations you want to avoid. This is a picture of a similar virus called MERS-CoV that somebody posted on Twitter. And this is a wedding in Korea where one person was not wearing a mask out of the entire group. And if you look carefully to the side, there's another person who looks like he's coughing into his hand, who's also not wearing a mask. So that's what you don't want. You want to have everyone masked around you. Those few people who are not can be problematic at times, particularly for somebody who is undergoing cancer therapy, who is at risk. So you can't change who you spend time with, but you can really have strong conversations with the people around you that you're at particular risk and you want to be protected, and the masking is important to you. I also want to mention depression and isolation are real. Depression is always a risk for cancer patients. To full disclosure, I have also been treated for cancer, and I know how difficult that can be. And so it's really important that we understand what this means, particularly with isolation, masking, and all the other things we're asking people to do. Life and family support structures can really be stretched. For many women who are going through breast cancer therapy, they have childcare issues and schooling, which has become an extra stress as they're doing this at home on a computer. while trying to still do their jobs in some situations. Caregivers can really struggle to juggle all the different things that they have on their plate. The lack of sunlight and self-isolation can be very difficult. I imagine what it's like for a cancer patient who lives alone, who has very little social contact, and that can be very difficult. I know for myself, I've gotten a lot less exercise. I've eaten not as well. I have a lot of socialization that has gone to the wayside because I've been working really hard and staying at home whenever possible. I'm doing this talk here. I'm not in Chicago with all of you, and I'm giving it from my home because I'm not at work. I'm working from home whenever I can. And then, when you're looking at the news, you see a lot of news that just feels hopeless. Lots of cases, you're hearing young people dying. A lot of what's reported in the news are really bad outcomes, and that can be really hard for people to see. So I focus the last C is on take care of yourself. Really important. I cannot say that enough. Eat healthy diet if you can. Sounds easy, but as much as you can, try to do that. Get a little bit of exercise. Get up and go walk around the block with your mask on. Take your dog for a walk if possible. Get good amounts of sleep. Don't stay up late as much as you can because that can be quite difficult. I can't speak from experience because all I do is stay up late, but I'm going to tell you to do the right stuff. Spend time with family and friends socially and socially distance if possible. You can have a barbecue in your backyard, at least now, before it gets super cold, where everybody can be there and be distanced. You can be in a household and be somewhat spaced out from each other, that you can be somewhat protected. But do it very carefully and with small numbers. And as much as possible, think about bubbles you can create of small family clusters or people that are friends that you know are going to be very closely protected and cautious around you that you can see on a regular basis. Love your pets. My dog has been critical for helping my wife and I to sort of deal with all the challenges we've had. Incredibly thoughtful and very great way to relax when you get home. Never judgmental about how you look, I can tell you that. And then get comfortable with video chats. It doesn't feel great all the time to be talking through a computer screen, but it can also be a really important way to talk about your stresses and to alleviate some of how you're feeling with others. That's a really hard thing to do, but really important. So as much as possible, have those conversations and get out there and let someone know you're struggling. If you're feeling really down, you must tell your team, otherwise they can't help you. And if you're ever feeling suicidal or are really struggling, make sure you call the depression hotline and let someone know ASAP. Because all of you going through therapy are important. You have a lot to give, and it does feel hopeless at times, but I promise you there's people who care about you out there. So don't let that get away from you, and care about yourself. You need to really focus on yourself as much as you can. So remind your friends, family, and colleagues, this is our logo here in Washington, but mask up. And if you're on Facebook, many of you, remind people on Facebook that masking is important to slow this progression of COVID-19 down. I couldn't do any of this. This is not actually me. I just grabbed this from the web, but it is a teamwork that has made all of this possible. It's not me. I certainly spent a lot of time doing this, but it's basically been my life for the last 6 months to 7 months. But there's a ton of people who have collaborated with me to make this possible. And I will tell you, we're all on Zoom way too much these days, but we've been able to get through it. And I think nobody does this alone, whether you're a cancer patient, you're a cancer provider, or a cancer center. So I think with that, I'm happy to answer any questions. My email is below if you have questions directly from me. And my Twitter handle is attached as well if you'd like to reach out to me more privately on either of those channels. And I think that's it, guys. So I'm happy to answer any questions at this point.
Thank you, Dr. Pergam. That was great. We do have a question in the chat. So
okay.
Kathy from Iowa, so we don't have just Chicago here.
That's okay.
She's a metastatic breast cancer patient, and she is on IV chemo. She's wondering, should she also get the flu shot and or the vaccine for COVID?
Yeah, so great question. Let's focus on the one we know the answer to. So what I always tell patients about flu vaccine is talk to your cancer doctor about it. Usually with episodes of chemo, you can time it at a good time where it may not be 100% protective, but it will give you some protection. And so I would talk to your team about when would be the ideal time during your cycles of chemo that might be a good time for you to get vaccinated. So have that discussion with them and get your vaccine if possible during a period in between cycles. I also would really encourage you, when we think about vaccination, is also the cocoon around you. So talk to the people that you are closest to and the people that you're going to have the most interaction with to have them get vaccinated. The more of them that get vaccinated around you, the more you're protected to potentially have them bring it home or to you in a public space. And so another really great way to sort of protect yourself is to get the people around you vaccinated to protect you. So I really encourage both aspects as much as possible. And whenever possible, you have questions about when to get vaccinated, your oncologists are very bright. They can get this organized for you. And most cancer centers have plans for when they should do vaccines for patients undergoing chemotherapy. For some patients, it may not be a good time. They may have specific reasons for you not to get vaccinated, so keep that in mind.
Okay, great.
And then before we go on, just really quickly about COVID vaccine. I didn't answer that second question. Yeah. That's a hard one. I don't know the answer. So I don't know when it's going to be available. So I would say wait and see. I don't know the answer for when that will be available. I think we need to do more studies to evaluate how well it works in different cancer populations. So I think that's an unknown question right now, but I think one that's going to be really important over the next year or so. But great question.
Thank you. There was also a comment saying, excellent presentation, love the extras about depression and other issues. We are all trying to live life and it's hard. So
yeah, I will just say, guys, if you think that your providers don't feel different, they feel the same. What's hard is, and I would encourage you, all of you, to just say to your providers who are taking care of you how much you appreciate them being there, because many of them are spending countless hours making sure that they're providing care for patients. It's stressful. It is hard because many of them in similar situations have kids at home where they have to school. They can't send them off at the moment in some places. And it's really hard to be working in spaces where they're worried about getting infected by going to work every day. So every healthcare worker who is out there on the front line is really spending a lot of time doing that. So as much as everyone who's a patient is feeling this, I promise you all of us are too. So take a moment to sort of give each other virtual high fives to say, we're at this, we've got it. We need to support each other, both from the patient and the perspective of the healthcare workers too. So we will do all that we can to make sure that you guys are protected. And we want you to live happy and safe lives. But please also reach out if you're struggling. It's so hard. This is a very strange time for all of us. And I think not all of us understand when these kind of challenges present. So please be super cautious and don't be afraid to say when you're struggling. There are resources and ways that these places can help you get the support you need.
Thank you. And I want to high five you. Thank you so much for all the work you're doing with research and everything, and just, getting to the bottom, getting to the bottom of this, figuring it out. It is a difficult, it's just the first time. Let's see. I have another question. Can you discuss what you think it will take for the pandemic to be over? So I know you've talked about masking and social distancing, vaccines, but how would it look like? How can we consider a pandemic to be over?
Yeah, I think the way that I would think the pandemic is over is we have vaccines that really work well to get the ability of the virus to transmit to drop substantially from where it is now. That we don't have to do the levels of social distancing and masking and other things that we're currently doing now. I would also say that if we had a treatment available that we knew could really get things under control and delay people from going on to developing symptoms or to prevent transmission, that would be critical as well. So there's a couple of different ways that I think this could move forward. I don't envision the vaccine is going to be perfect, but if it can decrease the amount of transmission, that will be helpful. I think at some point, there's going to be enough people that slowly get infected at low levels that eventually there'll be larger numbers in the community that are already have been exposed. And so I think at some point in time, it's just a slow process as well. We want to make it slow because we want to protect as many patients as we can until we have other therapeutics available and vaccines available. But there's also just a natural progression where there's going to be enough people eventually infected that just the transmission begins to dissipate. Some places like Sweden had initially tried this. I think they've revamped and are now going to more of a lockdown strategy. So I think in general, it's going to be a while before we get out of this. I would love to tell you I could give you a date and a time, and I could say, oh, well, we know it's this number of patients who are going to get infected, and this is the rates where we'd expect it. It's going to take us some time to know. So I think it's going to be a combination of vaccines, eventual therapies, and some what we would call the beginnings of some herd immunity that will help together to sort of bring down the transmission levels. And we start seeing less cases in our community would be my guess. But I can't specifically give you a magic number, a magic time frame when that's going to be.
Yeah, I know there's a lot of unknowns still.
Yep, still remains unknowns in this particular disease, that's for sure.
Yeah. All right. Someone in the chat said very good info, so thank you for that. And also thank you for reminding us to thank our oncologist. Excellent reminder. I just want to see if anybody else has any questions. Feel free to unmute yourself as well. And if you're in Zoom, if you're on Facebook, you don't have that ability, but please.
And I would also comment that if people don't feel comfortable asking a question on this chat because of some personal question that they want to email me directly, they're welcome to. Okay? I'm not always the best at responding quickly, but I will do my best. You can put in the intro, you can say Komen Talk question as your intro to the email. That might be helpful for me to be able to know it's from this particular talk.
Okay, that's great. Yeah, thank you so much for sharing your email with everyone.
No problem.
So yeah. It looks like we don't have any other questions. Let me just check Facebook. Yeah, but so no more questions, but feel free to email Dr. Pergam, also on Twitter. And then thank you so much again for coming and presenting to us, giving us this information.
And I just want to apologize again. I was supposed to give this talk last month, and my internet went down, and that's just the reality of COVID in the real world. So I'm so happy to have this chance to give it again. I also did talk to the team about potentially doing a talk later in October, since my initial topic for the Komen session in Chicago was going to be about marijuana and cancers. So I think we're going to try to talk about that at a later date. So people can stay tuned. Hopefully that'll be some more information coming your way, specifically addressing that, which is a really interesting space, and I'm sure it will be interesting for a lot of folks who are listening in today.
Yeah, I know we have a lot of interest in that topic, so we'll get to talk a little bit more about that, get the information out, and hopefully do something in October for Breast Cancer Awareness Month. So
okay, perfect.
Thank you so much, everyone. Have a great day.
And all right, thank you everybody for listening in.
Bye.